Good day, colleagues. Thank you for joining this webinar on delivering maternal and child health and PMTCT services during COVID-19. I am Dr. Shanti Singh Anthony, Knowledge Management Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP. This is a PANCAP PAHO webinar. I extend a warm welcome to you on behalf of my director, Dr. Rosman Adams, and on behalf of the Pan American Health Organization. We're pleased that you're able to join us once more as we continue to share knowledge that is current, evidence-based, and relevant at this time. Yesterday, the 11th of June, the World Health Organization reported a cumulative total of 7,237,958 confirmed cases of COVID-19 and 413,372 deaths. Further, 128,490 new infections were confirmed for yesterday alone, with 5,347 deaths. As we continue to play our parts in responding to the epidemic, we at PANCAP are pleased to continue this webinar series, focusing on the different aspects of the response. Today, we will continue this discussion, and our presenters will share with you the importance of delivering maternal and child health services, and they will speak with you about the prevention of mother-to-child transmission of HIV and syphilis. Before we proceed, two important housekeeping points. First, your mics are muted, and if you have any questions, therefore, as the presentation progresses, please type and submit these in the question field on your webinar panel. We will address the questions during the question and answer segment at the end of the presentations. Second, please be informed that we are recording this webinar and will share the recording on PANCAP's website and social media platforms for the benefit of those persons who could not have attended this live session today. At this point, without further ado, it is my pleasure to introduce our first speaker for today's session, Dr. Narine Singh. He is an obstetrician gynecologist with more than 20 years of experience with the Guyana healthcare system in many capacities, including as the Director for Regional Health Services for the Ministry of Health. Dr. Narine Singh is currently a Senior Registrar in Obstetrics and Gynecology at the Georgetown Public Hospital Corporation, Guyana. He is also an Associate Professor in Obstetrics and Gynecology at the University of Guyana School of Medicine and at Textilia American University School of Medicine. I now hand you over to Dr. Narine Singh, who will speak to us about maternal care during this time of COVID-19. Dr. Singh.
All right. Good morning, everyone, and welcome to this PANCAP PAHO webinar, delivering maternal and child health services during the COVID-19 crisis. As you know, that the COVID pandemic has had a tremendous impact on our lives, both economically and financially, but more especially on our healthcare services. One area that has been affected is the provision of essential health services. Due to the COVID crisis, many health systems have had to take up, many of the essential health services have had to take a back seat as we deal with the COVID crisis, providing provision of care for the increased demand by COVID patients. Many of our financial and human resources have had to be diverted for the care of COVID patients. And so, as a result, essentials or the routine health services that we would have provided normally have had to take a so-called backseat. This, especially in the case of maternal and child health, was something can impact on our healthcare system. As we know, because maternal and child health cannot wait. It's not something that we can wait until after the crisis is over and then started looking back at it again. We have to continue these services. And so we have to look at ways on how we can adapt our system to provide these services while at the same time dealing with the COVID crisis. For example, because of the COVID crisis, we have seen many patients not attending antenatal clinics. some healthcare, some reproductive health services, such as family planning services, have had to be curtailed. Patients are not coming to the antenatal appointments because of fear, transportation, disruption of transportation issues, and sometimes because of misinformation. This, we know, if it continues, can impact negatively on many of the gains that we have had over the years as we try to improve our maternal mortality and morbidity. And so, and it is shown that in the past, like whenever there have been crises, these services, we can have an increased preventable morbidity and mortality from these negative effects. So so as we move forward and try to deal and live with COVID until at that point in time when we have the vaccine or probably the transmission is almost low, we will still have to find ways on how to continue to provide maternal health services. And so countries or health systems will have to look at innovative ways and how we continue to provide health services, both antenatal services, delivery services, and postnatal care, and also family planning services. So there's a lot of, we'll have to go back to the drawing board and look and see how we can adapt our present, look at how we provide these services, and look at ways how we can continue to provide these services without having these disruptions. For example, like in the antenatal services, we know that many patients, because of the recent misinformation and fear of contracting COVID, if they visit health facilities, have actually been staying away. So one of the things that we need to start working on, and health systems need to start working, is information campaign, and to educate the population, especially those patients who are those persons who will need to access antenatal service, that these services are still provided. It is safe to come to a health facility once they follow the precautions, the IPC precautions, and that these services are still being provided. Because if they stay at home, things can go wrong, and you could have unnecessary morbidity and mortality resulting from them. Secondly, like the ways of how we conduct antenatal care. Like in our system in Guyana, we have usually most of our primary care facilities will have one clinic per week of antenatal care, sometimes 20, 35 patients for a morning session. That will have to change because we can't have everybody coming to the clinic at one session. So ways like splitting the clinic, doing or we could actually have staggered appointments and appoint people based on the time, and you have maybe more than one antenatal clinics per session. So these are some innovative ways we can look at and need to start implementing so that we can continue to provide the services. For example, and this is also an opportunity for the primary healthcare centers to start taking up the challenge. In the past, many times antenatal mothers would flock to the central hospitals, and then they will be overburdened. And so now some of the low-risk pregnancies can be shunned down to the primary healthcare facilities, where they can deal with those cases and only be seen at the higher or the high-risk clinics if they are referred. And in this way, we can prevent patients clustering up in clinics and having them exposed at risk of exposure. For the delivery service, as we know, it's recommended that every mother should deliver in a certified healthcare facilities by a skilled attendant, and this is usually in a hospital facility. We want all women to come to hospital. Recently, I've actually been we are hearing of issues, women asking midwives to go to their home to deliver them. We want to discourage this fact because we know the risk that involves, and so we want to assure them that it's good to come to hospital to deliver. hospital would need to make changes, like changes in their in the delivery room, have special facilities for those patients who might be suspected cases, special delivery room, and so this will call for some changes in the infrastructure. We will need to do special isolation delivery room, special units where mothers who might be positive can come to delivery, and also the patients who are not infected to also be delivered in those facilities. So this is things we have to start looking at. Health systems will need to start making the adjustment. Already some facilities have done it, but COVID will be with us for a while, and so we'll start need to making these changes. Postnatal care should be continued. Those high-risk mothers can only come to the high-risk clinic. The low-risk mothers can be seen at the district health centers where there's not so much patients, and so we don't have this clustering up of patients. So there's a lot of innovative ways we can tweak the system as it is presently. We need to look at it and see how we can change the system, but at the same time continue to provide these essential services. Because if not, if these maternal services are decreased or are not being provided on a regular basis, we would see the consequences of it later on. Increased maternal morbidity and mortality, and that is something that we are strongly we are fighting a lot to get our mortality figures down, our morbidity figures down, and we don't want to go back, slip back into the system, into the era where we had high maternal mortality. So the gains we had over the years, we need to maintain them by keeping these essential services, continue to provide these essential services even in the midst of the COVID crisis. I know that it will. That's why we need many of the health systems, the health administrators, to start looking at ways and means as we emerge from the COVID crisis to see, because recently we know there has been some slowing down of the essential services, but we need to come back and start, because we have it will be with us for a while, and it will call for some changes in our system, tweaking in our system. The WHO has put out some recommendations on how we can adopt the system so that we continue to provide these services, because we don't want people to think that our patients, that our mothers, to think that, well, these services are not provided, it's not safe to go to the hospital, we can stay at home and deliver like we used to do years ago, and we slip back into the situation of high maternal mortality and morbidity. So during the time of COVID, we have to look back. Health systems, health administrators will need to start putting a system in place, looking at how we can tweak the system to make it compatible so that we can ensure that these services are provided on a daily basis, 24/7, and it's not not to reduce the level of services, but to ensure that it's continued. So that's my take. I have some slides regarding antenatal care. We talk about spacing out the visits, and WHO is recommending that we should have at least 8 antenatal visits. That is still under discussion, but most mothers, low-risk mothers, should have at least 8 antenatal visits. Delivery care, as I mentioned, that we will need to ensure that mothers still come to hospital. That will need some change in infrastructure and availability of space for patients who are COVID positive versus those who are negative. Breastfeeding and COVID is something that has been come up a lot since the COVID started, and many mothers have been asking if they should breastfeed their babies in these times, if it's safe to breastfeed. As the evidence has shown that there's no viral particles that have been detected in breast milk, and so the recommendation is to still breastfeed. You can continue to breastfeed for those who are, especially a mother who might be positive and want to breastfeed. Once you take the necessary precautions to wear the mask and wash your hands while breastfeeding, we still recommend this skin-to-skin contact at delivery. Once the mother can wear a mask and prevent transmission, because we know that the importance of this breastfeeding and the importance of breastfeeding during the first 6 months of life. So those are some of the important aspects of provision of essential maternal services that we should continue to ensure that these services are provided on a daily basis, on a regular basis, and that there's no reduction in the provision of these services. That's my my presentation.
Thank you so very much, Dr. Narine Singh. I think we've gotten some really very key messages from you. Thank you for reminding us of the importance of delivering maternal care to our pregnant population, our pregnant women. I think it's interesting that you noted the fact that there has been an increase in the request for home delivery, but at the same time, making the point that there could be the risk of increased morbidity and mortality. Some interesting strategies, nothing that we don't know of, but the fact that we should be increasing the number of antenatal clinics so that we can accommodate the needs of everyone. Being able to decentralize our postnatal care, shifting much of that to our primary health care setting, I think it's really important. But I think one of the resounding messages is that COVID will be with us for a while, and therefore we need to repurpose to really fit the current environment in which we're working. So again, thank you so much, Dr. Narine Singh. At this point, it is my pleasure to introduce our next presenter, Dr. Narendra Singh is a neonatologist intensivist and an associate clinical professor at McMaster University, the University of Toronto, and Queen's University. Dr. Singh is also a fellow of the American Academy of Pediatrics and the American College of Critical Care Medicine. He is currently the program director for the pediatric postgraduate program at the University of Guyana and an external examiner for the University of Guyana in the undergraduate medical program. Dr. Singh has authored over 100 peer-reviewed articles and abstracts, a handbook in pediatric critical care, and chapters on the same subject. I now present to you Dr. Narendra Singh. Where is
Okay.
Dr. Singh?
Yes. Can you hear me? Hello? Sorry.
Hi, Dr. Singh, please proceed.
Yeah, can you hear me okay, Shanti?
Yes, I can.
Sorry about that. Anyway, thank you very much for the opportunity to present today. I think you would all agree with me that we as healthcare providers are in an unprecedented time in our history of providing healthcare. We're faced with a pandemic that's caused by a virus that I would describe as being diabolical. Diabolical in the sense that every day we're learning more and more things about this new virus, and more illnesses seem to be cropping up more recently in the pediatric population. One of the things that's really important for us as healthcare providers and folks that develop policies and procedures is we should be staying abreast with the new evidence that are coming out every single day. We need to stay agile, and we need to pivot with respect to our policies and procedures as it relates to everything that's COVID, and particularly in the maternal and child health programs. I think this slide, I think, speaks volumes for what we're learning and how long it's taking us to get to a point where we learn as much about this virus as possible. This is actually a policy and procedure that's developed by the Royal College in the United Kingdom, and they're actually on version 10. What that says is that from the first version to the 10th version, we've learned so much that we've had to modify and we have had to pivot and be agile with respect to our policies and procedures. So I think we all need to be aware of that policies that are developed today might change tomorrow. It may change next week based upon new evidence that's ongoing with this particular virus. So what do we know so far? As been stated previously, the virus is not present in breast milk. The virus is currently not present in vaginal secretions. And I think it's important to understand this because this is the basis for which we will develop policies and procedures to care for our moms and babies. So it's not present in breast milk. It's not present in vaginal secretions. It's not present in umbilical cord blood, except there are 2 cases that we found where there was PCR positive. And I'll speak a little bit about this in a moment. There's 1 case that's described in Iran where it was present in the amniotic fluid. The mother, unfortunately, was critically ill to the point where she passed away. The baby was born 24 hours, the COVID was negative, the PCR was negative. At 48 hours, it became positive. The question about vertical transmission is still a bit unclear because there have been a couple of cases where there's IgM positive babies. And as we know, the IgM antibody does not cross the placenta. So the question is, did these babies develop the infection while in utero or not? The point that I'd like to make is that there are these isolated cases in the umbilical cord, the amniotic fluid, vertical transmission, and the methodology and the sensitivity of the tests have been brought into question. I think when we look at all of the cases around the world in the maternal and child health domain, the conclusion is that it is very, very low overall maternal fetal transmission. Again, there's these isolated cases, but overall, there's very little maternal fetal transmission. So when we develop our policies and procedures, we really should keep this in mind as we talk about deliveries of the babies, resuscitation, neonatal care, etc. So the next slide, I'm going to focus a little bit on some of the key things around the delivery. And as a pediatric intensivist, this is my involvement, generally speaking. All institutions have policies and procedures in terms of who and when the team should attend the delivery. So for example, in my institution, if you're less than 35 weeks gestation, that's a premature baby, the team should attend. There's stigmaconium. If there is choreo, if there is fetal distress, then the team should attend. We should try to keep the numbers to a minimum. So not, 5, 10 people, just a minimum number of people that's essential for resuscitating the babies. As has been stated previously, skin to skin is continued in stable babies, and delayed cord clamping is encouraged, especially if the baby is stable. If they're unstable, obviously you want to clamp the cord quickly and hand the baby over to the neonatal team. Let's focus briefly on mothers who are either asymptomatic with COVID or they're suspected. What is currently recommended is you can, and we do that at our hospital as well, we have an overhead warmer, babies are born, moms are asymptomatic or suspected, they're resuscitated more than 2 meters away from the mother by the pediatrician or the nurse with full PPEs. If mothers are symptomatic and require either aerosolized generated medical procedures or they require a general anesthetic in an OR, then what we recommend is that the baby should be taken from the operating room into a separate room for resuscitation. Clearly, if this is not possible because of constraints, the baby should be resuscitated at least 2 meters away with all of the staff in full PPEs. Let's focus a bit on the actual process of resuscitation. So based upon what I talked about briefly in terms about evidence of transmission, all staff caring for babies should have full PPEs. If a baby requires positive pressure ventilation, either with bag and mask or a T-piece, that could be done very safely, and it's not necessary actually to have a filter on the T-piece resuscitator. Again, remember, for a baby to generate aerosolized virus, they have to be infected, or their lungs have to be infected. And there's no evidence at the moment from the literature that any babies have so far been born with an infected lung or with pneumonia. So if the babies need PPE or they need a T-piece resuscitator, don't delay this. This has to be done quickly. Similarly, for suctioning, if there's thick meconium, if there's liquor, if there's blood, and the baby is in trouble, suctioning should be done with the staff wearing appropriate PPEs. With respect to intubation, many policies and procedures recommend if you have video laryngoscope, use it, but many physicians are not comfortable with that. They don't have the video laryngoscope available. So direct laryngoscopy with intubation is recommended, and this should not be delayed. And it's thought that direct laryngoscopy in a newborn or a preterm is very safe as long as you're wearing the PPEs. This is different from the adult population where they're actually aerosolizing the virus. Babies are not doing that. So it's very safe to go ahead and provide direct laryngoscopy for intubation. Now, we should all follow the same NRP guidelines. There's nothing different managing a COVID baby with respect to providing chest compressions, with providing positive pressure ventilation, with providing IVs and EPIs. They should all be followed according to the appropriate and current NRP guidelines. Once you've stabilized the baby, it's important to transport the baby to the NICU. If you have in your facility a transport incubator or an isolette, that's the ideal way to transport the baby by a staff that has full PPE. Now, once the baby gets to the NICU, remember that babies who are born to mothers who are COVID positive, whether they're symptomatic or asymptomatic, if they have respiratory distress, the likelihood of it being related to COVID is 0. Babies who are with respiratory distress who are born to COVID mothers would have the usual causes, such as RDS if they're premature, meconium aspiration if there's thick meconium, or transient tachypnea of the newborn, or other things such as cardiac. So the likelihood of them being having a COVID pneumonia at birth is 0. So the point I'm trying to make is that the primary illness have to be managed, and this is not COVID related, generally speaking. How do we physically manage babies who are born to mothers that are COVID positive? Ideally in an incubator. And if you have the facility to be able to do that, they should be managed in a separate room altogether. If you had more than one babies that are COVID positive, they can be cohorted together. If a baby requires CPAP or mechanical ventilation or high frequency oscillation, they should ideally be managed in a separate negative pressure room. If that's not available, a separate room altogether. If that's not available, then it should be the furthest away from any babies that are COVID negative. All staff should be wearing PPEs, and until such time as there are 2 negative swabs, at least 48 hours apart with respect to the babies. All NICU management guidelines, whether it be CPAP, suctioning, mechanical ventilation, provision of surfactant, high frequency oscillation should be managed as normal. So this is an overview of the neonatal care. Not too many different things except for isolation to provide protection for the staff primarily. Now, if we have a mom that is COVID positive, how do we manage the baby immediately after? Now, it is recommended both by the American Academy of Pediatrics, the Canadian Pediatric Society, and the UK Society that babies can room in with their mothers. And as been stated before, they should be encouraged to breastfeed. The CDC has some slightly different guidelines which suggest that they should be separated, so that's not quite clear. But most of our governing bodies recommend that babies can stay with their mothers. They should be breastfed, and moms should take the necessary precautions in terms of wearing masks, washing their hands, and cleaning the surface in close proximity. If moms have to be separated from the babies, for example, they have to go to the ICU to require oxygen or mechanical ventilation, it's not inappropriate to continue to use express breast milk. When should babies be tested? If mothers are suspected or are COVID positive. If mom is suspected to have COVID, we should wait until the test comes back before we test the baby. If mom is COVID positive, the first test should occur within the first 24 hours, so between 2 and 24 hours. If it's negative, it should be repeated again in 48 hours. One of the precautions to be taken to avoid contamination is to ensure that you clean the baby thoroughly, especially the nose and the mouth, so that you don't get a falsely positive swab. All staff should be wearing PPEs until there are 2 negative swabs. So this is how we generally care for the babies who are born to mothers who are COVID positive. Let's shift gears a little bit and talk about childhood vaccination and COVID-19. As has been stated earlier on, and we know from the World Health Organization that it's estimated that about 80 million kids are currently behind in their childhood vaccination. In the United States, as can be represented in this graph, since March, it's been shown that as many as 50% of kids are behind in their vaccination, particularly the ones less than 24 months of age. Why is this? Clearly because of the lockdown, because patients and parents feel very unsafe to use public transportation to go to the physician's office. Their physician's office, they feel, is very unsafe to be able to do that. So what do we need to do and what's currently being done? But before I get to that, why? So the things that we're most concerned about, obviously, is an outbreak of measles, polio, or diphtheria. And it's been clearly shown that if the immunization rate in a population falls below 95%, that we can have a significant outbreak of measles. The last thing we want is to have a resurgence of either polio or diphtheria. So as healthcare providers, we need to be very proactive. Now, how do we change this? So I think it's a matter of managing our workflow in institutions or in private offices where these vaccinations are being given. I'm a pediatric intensivist. I'm not a primary care physician, so I actually don't give immunizations. So I actually spoke to my wife, and I have to give her credit for some of this. She's the one that has her primary care office. So what they have done, and many physician offices are doing the same, they're being extremely proactive. They're going back into their database. They're examining their patient numbers. They're examining the ones that require vaccination, particularly the ones less than 24 months of age. They're calling them and reassuring them that they can come to the office because it is a safe environment. They're suggesting that patients come as one parent, and each parent and that parent should wear a mask. If the child is above 2 years of age, it's recommended also they wear a mask. Doctors are separating clinics into immunization clinics and non-immunization clinics. So in the mornings, they're doing immunizations. The afternoon, they're doing sick visits, or they're separating it by days. And they're ensuring that the entire office is properly sanitized in between these specific clinics. One of the things that my wife's office does is that they ask the patient actually to wait outside in the car. So when a previous patient leaves, they then call them and tell them to come back in. Before they enter the clinic, their temperature is being checked. So many physicians are being, and they have to be very proactive in identifying these patients, because if not, parents are going to stay at home because they feel extremely unsafe to bring their kids to an environment which they feel that they themselves or their kids could be at risk. So these are some of the things that they're looking at, and people are actually thinking outside of the box. And I'll give you an example. So this is Boston Children's Hospital, where they've actually got 2 ambulances that's fully equipped with immunizations, and they're actually going out into the various communities to make sure that they immunize kids, particularly the ones less than 24 months of age. Can you do this in your population, can you do this in your environment? Maybe, maybe not. But the point is, we need to be proactive, we need to think outside the box, and we need to catch up with these vaccinations, given the fact that we are at risk for a measles outbreak or a resurgence of polio or diphtheria or other illnesses as well. So in summary, maternal fetal transmission is very low. We need to take the precautions to protect the healthcare providers. We need to catch up on the immunizations to prevent outbreaks. And I'm going to share this slide with you because I'm finished my presentation. And the reason I'll share this slide with you is Dr. Singh had called me or texted me a couple of weeks ago to ask me whether or not I feel there would be a point in providing a presentation on this illness that's being described in kids, which is the Kawasaki-related disease, and it's called the multisystem inflammatory syndrome. This is a very busy slide. I don't intend to go through it in detail. However, I did put it on because this was developed actually as an algorithm by sick kids to address the issue of this new syndrome that we're seeing relatively infrequently, but it is there. So if you're interested, I'm going to ask Dr. Singh to share this algorithm with you, and I'm not going to go through it. So thank you very much for the opportunity to present to you today, and I'd be happy later on to take your questions. Thank you.
Thank you very much, Dr. Narendra Singh, for really giving us a comprehensive presentation and a really good overview of how to approach the newborn, beginning from receiving the newborn to caring for the newborn, and touching on vaccination strategies for ensuring that our children are vaccinated. I know that our next presenter, Dr. Natalia, is very much involved in vaccination, and I'm sure that she would also want to touch a little bit on that. I'm aware that in the region we've had good vaccination coverage for our children, so I think that's one of the gains we will not want to jeopardize at this time of COVID-19. It is my pleasure now to introduce our final presenter, Dr. Natalia Beer. She's a medical doctor with a master's in sexual and reproductive health. She is a technical advisor for maternal and child health services at the Ministry of Health in Belize since 2003. In this position, she's responsible for making recommendations based on evidence to improve policies and programs, and she coordinates the design, implementation, supervision, monitoring, and evaluation of different components under the maternal and child health portfolio. She also guides sexual and reproductive rights, health promotion and information, and serves services to targeted populations and various aspects of MCH programming, Ministry of Health in Belize. And so I think Dr. Natalia is the best person to speak with us today on the prevention of mother-to-child transmission services during COVID-19. Dr. Natalia.
Okay, good morning, Dr. Shanti, Dr. Singh and colleagues. Thank you for the opportunity to join the discussion on the delivery of PMTCT services during COVID-19. The elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B is possible when inputs are available, including the informed consent from adults we interact with to get the desired outcomes. The continuum of care and the implementation of evidence-based interventions is key for a successful PMTCT program. In Belize, the transmission precaution measures for COVID-19 began around mid-January 2020. Since then, case investigation and contact tracing are a priority for the country. This case of COVID-19 was diagnosed on the 23rd of March. And after case number 18, we had 53 days with no case. to date, we have 20 cases, including 2 deaths. On June 1st, the World Health Organization issued an interim guidance on maintaining essential health services. And this interim guidance spelled out 10 different operational strategies for maintaining essential health services. For the purposes of PMTCT, I will make a reflection on number 6, which is maintain the availability of essential medications, equipment, and supplies as it pertains to PMTCT. In Belize, we do 3 testing for HIV-exposed infants. We do the HIV DNA PCR at birth, at 8 weeks, and at 12 weeks of age. The result is usually available in 2 weeks' time. However, during the first wave of the COVID-19, we had some difficulties. The first one was that the samples that we procure services from a private lab, they got hold up due to the irregular working hours of the lab that is reading our samples. The second issue was that the lab that is performing the PCR for the exposed infants is also part of the network of SARS-CoV-2 testing. So competing timing for the delivery of the results. So it took us a while to try to identify what did happen with these samples that we sent for testing. When we did identify the problem, we revisit the process that we have in place for the HIV DNA PCR and make the relevant changes. So today, we did not look at the airway bill as important information, but today now we get the airway bill and the shipment day. We now provide this airway bill to the private lab. This was not done previously. And if the parcel is not received in 3 days, the private lab has committed to pick up the courier before. This was not done usually. So we hope that these changes in the process will help us to avoid a repeat of the situation. So we have a backlog right now of about 2 months, and just during the first wave of the COVID-19. So PMTCT is an essential health service. And the 19th of, and before the first case in Belize, from the Office of the Director of Health Services, a guidance was issued to the health regions looking at the scale down of the MCH services, and this considering the transmission precaution measures that were recommended. Again, because we did not have cases for up to 53 days, then on the 8th of May, another guidance was issued to the regions, sharing with them that we need to move on now to scaling up back the services. And as we all know, in the different countries, and it's not, we can't go to the way how we were providing services, as mentioned by Dr. Narine and Dr. Narendra. We are scaling up the service, but cannot be like we used to do before. The PMTCT in Belize is a decentralized program. Women affected with HIV that are pregnant and their exposed infant can access the services in all districts, and these services are provided in all the health facilities. Maternal and exposed infants receive services for screening, care, and treatment. Exposed infants are followed by the pediatricians. We installed the hepatitis B birth dose last year in February. And our program is fully funded by the government of Belize. No out-of-pocket payment is required from families accessing the service. For 2019, we had a total of 34 HIV-positive pregnant women with 35 exposed infants due to one twin delivery. And we had a total of 18 pregnant women that was treated for HIV and syphilis at first contact, third trimester, and because we have seen recently that women are testing positive in the postnatal period, we instituted the testing for HIV and syphilis upon admission. Their status so that we can provide treatment to both the mom and the newborn. Our HIV algorithm was updated late last year. The screening laboratory was done using an inconclusive result. We offer the HIV DNA PCR for confirmation of the infection. And a situation like this presented earlier this year, and that was what triggered us to do the investigation of why we had the delay of the results from the DNA PCR that we are procuring abroad. So PMTCT, no doubt, is an essential health service, and we did some changes. Prenatal booking was done as a walk-in or via phone. This helped that when the woman was invited to come to the health facility, then she would spend less time in the health facility because she would go directly to do the laboratory and other tests that were recommended, her physical examination, and referral if needed to medical officer or specialist. The follow-up is done by phone, text message, WhatsApp, and even Facebook, and it has had a good acceptance from the women. And so far, this might be the way paving towards a new normal. The services are provided by public, private, and NGO. We collaborate and we treat care PMTCT as a public good. And the collaboration includes also data collection from the different sectors for us to build a national or country reports. What we have noted is that women and families that have pregnant women with HIV, there is a high burden of social determinants of health. And this is driving the stigma and discrimination, poor adherence to treatment in some cases, and also the public health nurses and the rural health nurses, they are going the extra mile, providing special services. For example, transportation if needed for the women to access lab and other exams, for the women to pick up their medication, to carry them to appointments with specialists, or even for the collection of the dry blood spot samples, which can be done at home or at a health facility. They're also referring for those who require support services to the Ministry of Human Development. This is a simplified version of the protocol for the management of PMTCT syphilis, and it has been used by the staff and it's very user-friendly. Our program is co-managed by the National HIV Program and the MCH unit. And at national level, we have a master sheet where we have one senior public health nurse assigned to co-monitor each case with the local team. Because of the amount of information that is required to achieve the results, we are considering and working towards having a web-based data collection tool. The region of the Americas, once again, is demonstrating leadership in protecting the rights of children, this time the right to be born free of HIV, syphilis, hepatitis B, through the validation of the elimination of mother-to-child transmission. The Pan American Health Organization is the secretariat for the validation committee in the region of the Americas. Worldwide, 14 countries have been validated so far, and 50% are from the Caribbean subregion. In closing, I would just like to remind our colleagues that PMTCT is a right and an essential health service. As such, the continuum of care does not change, irrespective of a pandemic, disease, or natural disaster. It requires commitment from all partners, and having a national program makes it sustainable because national programs are funded by the government. And as a right, efforts should be made to remove all barriers for women and exposed infants to have access to these services. Thank you.
Thank you very much, Dr. Natalia, for giving us a really good overview of the status of PMTCT, not just globally, but also importantly on some of the initiatives that you have put in place in Belize. At this point, I would open up for questions. Please continue to submit your questions. We already have a few questions, and I'll go through them. I'll ask the presenters to respond. I may identify a presenter to respond to a specific question. Other than that, all presenters feel free to add to any of the responses that one of your colleagues may have presented. So here is a comment, I think, not necessarily a question, a comment, sorry. The participant is saying that 8 antenatal visits, and this is directed to Dr. Narine Singh in particular, that the WHO guidance actually mentions 8 contacts and not 8 visits necessarily. And so there has to be a clear distinction in terms of non-physical visits and those done in the community. I don't know if Dr. Narine Singh would want to react to that comment. Dr. Singh?
Yes, the thing is 8 contacts does not necessarily mean 8 actual visits. But given in our situation where we haven't perfected the use of telemedicine or video calls or so on, in our situation, and given especially in our where we have large number of patients in rural and remote areas, it is kind of difficult to actually have contact, and so face-to-face contact is the thing that we will have to do. I hope we will get there as we put infrastructure in place, but that is something we'll have to work on. I mean, as we develop and put more systems in place. But previously it was 4, but now we are going for 8. But it depends upon the risk of the pregnancy. If it's a high risk or a low risk pregnancy, sometimes we can don't really need 8 actual visits. But yes, that is contacts, because you need to check at certain specific time during the pregnancy, have some kind of consultation with the patient. In our situation in Ghana, it's probably not possible yet because we haven't had the infrastructure in place to do those type of telemedicine and video calls and so on with our patients. But it's something that maybe the health systems managers or so on will need to start looking into, because this is something that can be put in place, especially in the urban setting. But in the remote areas, it will be difficult to do that because we don't have the infrastructure.
Thank you, Dr. Singh.
That's my answer. Mm-hmm.
Yeah, thank you, Dr. Singh. I have a question here for Dr. Narendra Singh. The participant is asking for some clarification on early cord clamping that is being advocated, and is noting that this could be in conflict with the evidence on the benefits of delayed cord clamping, especially for the preterm infant.
So let me just get some clarity on the question. So the question was, should we be doing delayed or should we not be doing delayed chlor clamping in premature babies? So the point I was trying to make is that if the baby is out and clearly in some distress, then you want to clamp the cord quickly and provide the baby to the team for resuscitation. If it is a preterm baby that's not in any obvious distress, then clearly they should be delayed cord clamping. So if I misstated that or you misunderstood that, my apologies. Only if the baby is in distress. So for example, if the baby is clearly in distress in utero, there has to be an emergency C-section. Baby comes out and is clearly flat, has no tone. The clamp should be cut fairly quickly, and the baby should be given to the resuscitation team. If it's a premature baby that's being delivered and the tone seems well, then obviously they should be delayed cord clamping. I hope that answers the question.
Thank you, Dr. Singh. Here is a question, I think, specifically for Dr. Natalia, and maybe you can contribute, Dr. Narendra. The question is, a child born to mother who is positive for hepatitis B and who receives hepatitis B at birth, does it necessitate giving immunoglobulin, or will the hepatitis B vaccine given to the baby is adequate? Dr. Natalia?
Yeah, thanks for the question. Indeed, it is recommended that we give the vaccines at birth before the 24 hours, and it is also recommended to provide the immunoglobulin, but that is a product that is difficult to resource, and we as a country have had challenges even outsourcing the same product. But there is sufficient level of coverage with the hepatitis B vaccine at birth.
Yeah, and in our institution, we follow the same process. So if a mother is hepatitis B positive, baby does get the vaccine and the hepatitis immune globulin within the first 24 hours. The only time that we just give the vaccine to the baby is if mom is negative and dad is positive. The baby just gets the vaccine and that's considered adequate.
We are providing blanket the hepatitis B birth dose because of the issues with screening all pregnant women for hepatitis B and for the issue of the times the immunoglobulin. So we provided blanket.
Okay, here's another question. I think, Dr. Narendra, you spoke on this during your presentation, but maybe there is more that you can add, and also for Dr. Natalia. When breastfeeding baby to COVID-19 positive mother, can those baby be separated and express milk given?
Yeah, so what's recommended at the moment is if the mom is asymptomatic, then the baby should be with mothers. The babies can directly breastfeed if mom takes the precaution of wearing a mask and washing her hands and cleaning the surfaces around the area. If for any reason the baby needs to be separated from the mother, for example, if the mother is symptomatic and needs ICU care, the breast milk can and should be expressed because there's no virus in the breast milk, and the baby can be fed by a bottle or other measures. So yes, we do use the express breast milk with COVID positive mothers who have to be separated from the babies.
Any comment, Dr. Natalia?
We don't speak much about the consequences of separating the newborn from the mother. That sometimes have lifelong consequences on the individual. But the evidence so far is, WHO is recommending also, that we must try our best to keep the binomium together. And some specialists are still resisting even women
Oh, I'm sorry. I think we're having some difficulties hearing you.
The risk based on the evidence that is available.
Okay. So the next question is to Dr. Narendra Singh. Given the current, Natalia? Okay, we had some difficulties hearing you, so I'll move on to the next question. And as I was saying, this question is to Dr. Narendra Singh. The question is, given the current pandemic situation, social distancing, and other health protocols in place, are there presently high-definition monitors that can easily detect fetal heartbeat, just to lessen the length of contact with mother and healthcare provider?
Could you repeat the question, Dr. Singh, please?
Given the current pandemic situation, social distancing, and other health protocols in place, are there presently high-definition monitors that can easily detect fetal heartbeat?
That's a really good question. As far as I know, certainly our institution, we use fairly standard fetal monitoring at the moment. But as far as I know, we don't have any of those monitors that I'm aware of. Much of the monitors that we have are actually Bluetooth and Wi-Fi, so that it can be hooked up to nursing stations where the fetal heart rate can be monitored and monitored continuously. But yeah, so to some extent there is that's currently available, so it could be done, from a distance away, and they don't have to necessarily be at the bedside. So there's quite a bit of that's ongoing. Certainly in our institution we have 30 odd delivery rooms, and they're all on special monitors that can be seen from the nursing station, so we can monitor the mother's vital signs, we can monitor the fetal heart rate from a distance. It's a good question, and I think the question relates to minimizing the contact with COVID-positive mothers.
Thank you, Dr. Singh. I have a few comments from Guyana. They're eager to share some of what they're doing, so I'll go through them really very quickly. This is from the MCH Department, Ministry of Health, Guyana, congratulating you, Dr. Narine Singh, on a good presentation. But at the same time saying that the MCH Department has provided written guidelines to all regions in Guyana, and we have 10 administrative regions, on providing maternal care in the context of COVID-19. This protocol is regularly updated. As updates are reviewed and accepted from the World Health Organization, there are very few challenges identified, but no service in particular has been interrupted since the MCH services are deemed essential. And I think that's the point that Dr. Natalia has made throughout her presentation, that MCH services and PMTCT services are essential services within the healthcare system. Additionally, I think the Guyana program noted that support has been given through a restructured network. MCH is seeing that in each region, regional supervisors and regional health officers have access to timely communication and support from the central level. There has been a call hour instituted at most health facilities, and calls are made to the client from a call script that has been pre-approved and prepared by the MCH department. I think Dr. Narendra Singh, you made reference in one of your slides that we have to be innovative, and I think calls were one of the ways in which you suggested that we tackle the issue of vaccination as well. Calls have been made to clients from a call script that has been pre-approved and prepared by the MCH department. Call logs were designed and shared with health facilities. And as it relates to immunization, we also, and we meaning the Ministry of Public Health in Guyana, also have written guidances provided by the MCH department. So I want to thank the Ministry of Health Guyana, for sharing that with us. The next question is from Dominica. Thank you very much for a very informative and timely presentation. We do trial of simple telemedicine communication during COVID pandemic. This has worked really very well for us. Are there any considerations for the use of telemedicine services for our pediatric patients? Maybe I can ask you to answer that, Dr. Narendra.
So there are many institutions or many physicians and pediatricians in Canada, and particularly in Ontario and Toronto, including my wife. They have a separate cell phone or system whereby they're provided to all of their patients. So during the day, they call in, they leave them, or they send a text message saying they need to speak to the pediatrician. They set up a schedule, and the physicians would actually call each patient back. With each one of the patients, as you know, as physicians, many of these things can be addressed over the phone. For example, if they have a fever, most of these infections are viral, and they would provide them with appropriate advice. If they feel that these patients may be at higher risk for COVID, they would then advise them or triage them to a COVID center to be tested. If, for example, it's a non-infectious stuff, such as a rash, patients would actually take a picture and they would text the picture to the pediatrician, and the pediatrician would provide advice over the phone. If it's issues around vaccination, some physicians are actually doing the 2-month, the 4-month, the 6-month developmental assessment actually over the phone by questionnaires. They're then triaging these patients to their offices where a nurse or one of the other healthcare providers could actually give the vaccine. So they don't necessarily have to have direct contact altogether. And the point I was trying to make is that earlier on is that we have to be innovative. And many physicians are actually switching their practice to either call or video conferencing. And a smaller fraction of these patients are actually physically seen. So yes, it is possible that it can be done.
Thank you very much, Dr. Singh. I can see that Dr. Judy Nisbet has her hands up. Judy, if it'd be okay, I can ask that you type your question and submit your question in. We have a comment from Dr. Angela from UNICEF Belize, saying thanks to all of our panelists, very good presentations, and she made specific reference and commendation to the work done by Dr. Beer on the continuity of maternal child health services, especially in the area of immunization during COVID-19 pandemic. We don't have any more questions at this point in time. However, I think we've exhausted our time. Just a lot of comments that are coming in to say thank you very much for really good presentations, very informative. And so appreciation from our participants who are present with us this morning. At this time, it therefore brings us close to the end of the webinar. And so I would also like to, on behalf of PANCAP and PAHO, the Pan American Health Organization, say special thanks to Dr. Narine Singh, Dr. Narendra Singh, and Dr. Natalia Beer for really excellent presentations, taking us through maternal and child health care services during COVID-19 and really focusing on PMTCT. I think one of the key points, sorry, that I've neglected to mention in my introduction of Dr. Natalia is that she is a member of the Regional Validation Committee for the Elimination of Mother-to-Child Transmission of HIV and Syphilis in the Caribbean. So we were indeed in very good hands as we discussed maternal child health and PMTCT services at this time. Colleagues, we will send to you the presentations via email. You will receive these shortly. You will also receive a very short survey for your feedback on the webinar. Your feedback is really very important to us. It will allow us to better understand and therefore address the knowledge needs of our audience in the region, especially at this time. I encourage you, therefore, to take a few minutes and give us your feedback. It is really very important to us. Going forward, join us for our next webinar on June 26, where we will discuss the effects of COVID-19 on men's health and gender-based violence. We will share with you all the announcement very shortly. In closing, I encourage you to stay engaged with us. Visit our website, www.pancap.org, for more information on HIV and COVID-19 in the region. Check out our homepage for our COVID-19 dashboard, where we present daily updates on new infections in the region, and visit our COVID-19 webpage. I also highly recommend that you visit PAHO website, where you'll find a wealth of resources on COVID-19. And do also follow the PANCAP and PAHO social media platforms for daily updates on policy guidelines and protocols. Again, thank you so very much, colleagues, for joining us. Please stay informed and be safe, everyone. Have a good day.